Hi guys, good evening. Good evening, good evening, good evening. Can you all see me? Can you all hear me? शुरू करें. Good evening guys, good evening, good evening. Can you all see me? Can you all hear me? Hi, good evening. Hi Sheikh Fayaz. So, let's kick into our BLS. The last week, the week before, the session that we took was on the clinical, your risk factors for breast cancer, right? I'm great, thank you. Thank you for asking. Let's begin. ठीक है, चलो क्लास खत्म करें फिर आराम से बात करेंगे. So last time जब हमारी बात हुई थी, we spoke about all the risk factors that are associated with breast cancer. We spoke about a genetic risk factor also. तो genetic risk factor के context में ना, we have something called as the HBOC syndrome, right? So let's understand what does this HBOC syndrome stands for. We're talking about the HBOC syndrome. Now, HBOC basically stands for Hereditary Breast Ovarian Cancer Syndrome. It's a hereditary breast ovarian cancer syndrome. So, HBOC basically stands for Hereditary Breast Ovarian Cancer Syndrome, right? So, we call it as people to have an HBOC or the suspected patients who are going to have an HBOC. It is usually associated with BRCA mutation positive. It is usually associated with patients who are going to have BRCA mutation positive. Either it's a BRCA1 or a BRCA2, right? Now, if a patient is having a BRCA mutation positive, right? Now, another very interesting question is, in which patients would you like to test for BRCA mutations, right? Number one, let's say you had a female with a breast lump. I'm giving you a prospect out of it. Let's say you have a female who is 40 years old, who is, let's say, not in 40, presented to you with breast lump, right? On true cut biopsy, I found to be invasive ductal carcinoma. It has invasive ductal cancer. When we took a history, the patient gave the mother with a history of carcinoma breast, right? If you have a patient who is presented to you in these lines, right? Now, what are these lines that we're talking about? Number one, you have young female. Or else the last one, I'll just start male breast cancers. If you have a scenario that I've just described to you, that you have a female who is 30 years old, presented to you with the lump in the breast. Now, this is a very, very important scenario that I've just described it to you. Okay? So, you have a female who is a 30-year-old presented to you with breast lump. On a true cut biopsy, it came out to be malignancy. Gives a history of mother to have a breast cancer, and obviously, let's say some family history, or let's say just for the additional sake, I've added male breast cancer also. If any of them is there, all these patients must undergo a BRCA mutation or the BR. So what I'm trying to tell you is, this is the indication for genetic testing. In simple words, when would you like to get a BRCA gene mutation tested? Not every patient of breast cancer will go and order, no, ki jao, BRCA mutation test kara ke aa jao, right? Now, these are expensive tests, right? So obviously, like in India currently, it is going to cost you anywhere between 15 to 20,000 rupees. It's quite expensive, and that too if you have, a good connect. Otherwise, they can be anywhere up of 30K also. Now, so that is why we don't, order genetic testing for all of them. What is the indication for genetic testing? If you look at the current scenario, I've just listed out. Number one, if it is young female with breast cancer, so early onset of breast cancer. if there is an early onset of breast cancer, then you have first degree relative with breast cancer, first degree relative with breast cancer, presence of male breast cancer. All these are the indications for genetic testing. Right. Along with that, another indication that I can add here, if there is history of fallopian or the ovarian cancer. If any one of them is present, you need to go ahead with genetic testing, right? Just give me 1 second. Okay. Okay. Right. So these are the indications for genetic testing, right? Now, once you got a genetic testing, that is BRCA mutation, BRCA genetic component was done. What if you got a BRCA mutation positive, right? The minute you get a BRCA mutation positive, for this patient, I'm going to go and operate. We will do a modified radical mastectomy with lymph node dissection, all that will be done. But what additional you have to do? Any female who has a BRCA mutation positive, I'm going to screen all first degree relatives. I'm going to screen all first degree relatives for BRCA mutation. The first thing I'm going to do is I'm going to screen all first degree relatives, that is mother, sister, daughter, everybody, even the son, we are going to screen for BRCA gene mutation that is going to be present. Now, if let's say any one of the family member is positive, let's say we found that one of the family member that we have screened is found positive for BRCA mutation, is found positive for a BRCA mutation. We found that it is positive for a BRCA mutation. Now, the minute you get this news that the patient's family member is positive for BRCA mutation, the first thing that you have to see is the family status of the patient. Now, when I say the family status, the basic meaning of family status, it is the desire to have any more kids or further kids or not, right? Now, I have two components. Either the family status would be complete. That means patient says enough. I had all the kids I wanted. I do not want any more kids, right? So either the family status is complete where the patient does not expresses any desire to have any further kids. We call it as complete. On the other hand, if it is incomplete, that is patient expresses to have more kids, or let's say the patient is not married, or the patient does not have even one kid, so family status remain incomplete, right? If the family status is complete, this is where I would advise my patient that because you have BRCA mutation positive and that is associated with breast and ovarian cancers both, it is better to opt for risk reduction strategy. You got risk reduction strategy. If the patient family status is incomplete, I will assess the age of presentation. If the age is about 25 years or if the age is below 25 years. If the age is below 25 years, do nothing. Right, ask the patient to chill and ask to come back after the patient turns 25. If the patient is above 25 and family status is incomplete, this is where I will advise the patient to get MRI on an annual basis. So annual MRI, this is the screening that you are going to do. Along with that, advise the patient to complete family at the earliest. And once the family status is completed, then we will advise for risk reduction strategy. Then we will take the patient for risk reduction strategy. That is the basic objective. Okay? So age less than 25, we don't have much of problem there. So usually the malignancy won't develop here. So do nothing. After 25, every year get an MRI done, and meanwhile ask the patient to get the family status as early as possible. Get married, have kids, be done with it, and come back. Then we'll opt for risk reduction strategy. Now in a risk reduction, what are we going to offer? Now the risk reduction is that I'm trying to reduce the risk for breast as well as ovarian cancer, because BRCA gene is associated with both breast as well as ovarian cancer. So the goal here for risk reduction, it is to decrease the incidence of both breast cancer as well as ovarian cancer. So how would you be able to achieve that? Now the goal to be achieved, I can advise for number one, bilateral, that is both the breast, bilateral. I'm using the word prophylactic because the disease is not developed yet, so it's a precautionary measure. Bilateral prophylactic mastectomy, that means remove both the breast, right? Another one is going to be bilateral prophylactic salpingo-oophorectomy. So it is a bilateral prophylactic salpingo-oophorectomy should be performed. So either you do a bilateral prophylactic mastectomy or a bilateral prophylactic salpingo-oophorectomy has to be performed, right? So when you go ahead with mastectomy, remember it reduces the risk. It reduces the risk for breast cancer. It reduces the risk for breast cancer, not 100%, but close to 95%. There is still 5% chance of developing of breast cancer, whereas your prophylactic salpingo-oophorectomy reduces the risk for ovarian cancer, but here the risk reduction is only 90%. So even after removing both the ovaries as well as both the breast, it does not give you 100%, you know, ki guarantee ki aage jalke breast ovarian cancer nahi hoga. No, it is possible, but yes, it causes significant reduction. So hence, now this is the risk reduction strategy. Now, along with that, you can also start the patient on selective estrogen receptor modulator, that is your tamoxifen. Right. So tamoxifen is given as 10 milligrams per day, and this is the dose that we follow for therapeutic as well as your prophylactic measures, right? So this is what we call it as the risk reduction strategy, right? Again, very, very important concept. Even if you want to address any, you know, friends or any family member who is having a breast cancer, now this is what, or this algorithm is what we are going to look at. It is going to be quite important to understand, analyze ki kisme pehle genetic testing karana hai, and after you have gotten a genetic testing done, you need to analyze and assess that, you know, whether you want to go with prophylactic, you know, measures or not. As simple as that. Now, once you have this in control, we'll talk about the clinical presentation of breast cancer. So talk about the clinical features. We'll talk about the clinical features of breast cancer. So talk about clinical presentation of the breast cancer. Most of them is going to present to you with a simple presentation, that is lump in breast, right? So the chief complaint or the first complaint or the primary complaint would be simple lump in breast, right? Now when you ask more questions about it, the patient will tell you, number one, it is going to be incidental in onset. It is going to be incidental in onset. It would be rapidly increasing in size. This would be rapidly increasing in size. So it's an incidental in onset. It will rapidly increase in size. This is going to rapidly increase in size. This is usually a painless lump. So incidental in onset, rapid increase in size, and this is going to remain painless is the initial presentation of the patient, right? Apart from that, majority of them do not have much of the presentation. This is what they have. In few patients, because of cancer cachexia, they can also have significant weight loss. they can have significant weight loss. And we all know the definition of significant weight loss in cancer cachexia is when there is a weight loss of more than or equal to 10% of body weight. There's loss of body weight of more than 10% over a period of 180 days. That is going to be approximately 6 months, and this is what we call it as significant weight loss, right? So if there is a weight loss of more than or equal to 10% of a body weight over a period of 180 days or a 6 months is what we call it as significant weight loss, right? So initial presentation would be lump in breast, and there will be associated with significant blood loss, significant weight loss. That is an initial presentation. Later on, it can go into other spectrums as well. Now, if a female presents to you with this, let's talk about its clinical findings, and then we'll talk about various components, right? So on examination findings. So what are the findings that you are going to see? So whenever you want to examine a patient of breast, what is the position in which you would like to examine? It is going to be in a sitting position over a round stool. Now this provides you an adequate access, right? Now when you talk about this, what are the various positions in which you would like to examine the patient? Now take this as a representation of the round stool, and we will see that what are the various positions in which we could examine the patient. Right. So the first position that you usually see is where a patient is going to sit with both the hands by the side, and this is what we call it as a neutral position. The second position is where I would ask the patient to sit, but this time the hands will be over the hip. The third position in which I would ask the patient to sit is again sitting, but this time both the hands above the level of the head. And the last position, which is usually not preferred these days, is asking the patient to lean forward or to bend forward. So there are the standard 4 positions in which you would like to examine the patient. So the first position that you have seen, this is hands by the side. This is hands by the side. The second position in which you would examine is hands over the hip. It is hands over the hip. The third position, it is going to be hands above the head. The third position in which you are going to examine is going to be the hands above the head. Hands above the head. Hands above the head. And the last one is going to be bending forward. The last one is going to be bending forward, right? So you have Hi Nisha, I'm great. Thank you for asking. Thank you so much. I'm glad that I'm able to make a little bit of contribution to your medical journey, and that's the objective. Okay? Thank you so much. Chalo. So we have 4 different positions. You have the hands by the side, hands over the hip, hands above the head, and bending forward or leaning forward. Ab ye jo hands above, in a neutral position that you have, this is what we call it as the neutral position. Now in this neutral position, all the inspectory findings should be evaluated here. Now hands over the hip ka objective kya? What is the objective of hands over the hip? You ask the patient to put the hands, just not putting the hands, ask the patient to press the hip. Now when the patient presses the hip, what is going to happen? Now you try to press the hip, you see this muscle is going into contraction. What is this muscle? You feel it here. This is your pectoralis major muscle. So in hands over the hip, you are putting the pectoralis major muscle into contraction. It is you're putting the pectoralis major muscle into contraction. Now why it is important is When a lump which is present in the breast, when it goes deeper and infiltrates the pectoralis muscle. See, normally in a neutral position, if this lump is here, you try to move. See, your muscle is also moving, right? As the muscle moves, even the lump will also move. You will not be able to understand whether it is infiltrating the muscle or not. On the other hand, when you put the pectoralis muscle into contraction, now when the muscle contracts, now if there is a lump which is here, if the muscle is going to contract, if the muscle contracts, it holds the lump now. Now when the muscle is contracting, it tauts. As it tauts, it constricts the lump and the lumps get fixed. Now when you try to move, even if you put the muscle into contraction, you still be able to move the muscle, the lump in the direction perpendicular to that of muscle, but you'll never be able to move the lump along the muscle fibers. So what are you going to find? If a breast lump, it is infiltrating the, see, infiltration of pectoralis muscle or infiltration of any structure by lump or any swelling indicates malignancy. Benign lesions do not infiltrate. Now it is the malignant one which are going to infiltrate. Now as they infiltrate, they cause these problems. So clinically, how do you know it is a benign or a malignant lump? Ask the patient to put the hand over the hip, put the muscle into contraction. If the lump still continues to move in both directions, perpendicular and along the line of the fibers, it is a benign lump. On the other hand, if the patient puts the muscle into contraction and the lump is moving perpendicular, it is still restricted but moving, but it is absolutely restricted along the line of fibers, that indicates infiltration of pectoralis muscle, and that is why your hands over the hip is going to be quite important. Now hands above the head is what we call it as the Auchincloss. This is what we call it as the Auchincloss method of breast examination. Why this is important? This is the only method in which when the patient raises both the arms, what is he exposing? You are exposing the inframammary region, that is going to be evaluated, and you are exposing the axilla as well. So if you raise hands above the head, as you raise the hands above the head, you are able to expose the inframammary region as well as the axilla of the patient, and that is quite important for examination. That is why Auchincloss gives you the most important findings as well. Bending forward or leaning forward का एक ही concept था. If a lump is infiltrating the chest wall or the underlying muscle, normally, breast is a pendulating structure. When the patient bends forward, the breast should fall freely. On the other hand, if the patient is bending forward and breast is not able to fall freely, whichever where the lump is there, if that breast is getting restricted, the other breast is falling, the breast which is affected is not able to fall. What does it indicate? That means that the lump is infiltrating the underlying structures. So hence it is not allowing the breast to fall freely, because now breast is fixed to the chest wall. So bending forward or leaning forward was basically trying to tell you whether there is an infiltration into the underlying muscles or not. That can be evaluated with the hands over the hip. So you don't really need to do your matha garam. You got the idea? So there are the 4 different positions in which you would like to examine the patient. All of them are going to be important. So once you have examined it, now what are the findings that you have? Right? So findings associated with breast cancer. So we have findings associated with breast cancer, right? So what are the findings associated with breast cancer? So the first thing, we start from the center to periphery, we'll analyze everything. Now the first thing first, when you look at this as a representation of the breast, this happens to be the nipple and this is the areolar complex. This is the axillary tail of Spence. Every time we draw a breast, we'll draw this small triangle which tells you this is the normal extension of the breast into the axilla. More importantly, what is it trying to tell you? That wherever this triangle is, that this is the lateral and the other end is going to be the medial side. So this is the medial end of the breast, this is the lateral end of the breast, right? Now, we all know breast is divided into 4 different quadrants, right? On what basis? आपको लोग पता नहीं क्या क्या बताएंगे. I'll tell you the most precise and the correct answer. How do you divide the breast into 4 quadrants? It is not your mid-axillary line. It is not the one that is going through the nipple. All that nonsense is stupid. Remember, you have to draw 2 lines. Draw 2 lines passing through the nipple, perpendicular to each other. Draw 2 lines that crosses the nipple, perpendicular to each other, and they divide the breast into 4 different quadrants. This is what we call it as the upper outer quadrant. This is what we call it as the upper inner quadrant. This is what we call it as the lower inner quadrant, and this happens to be your lower your lower outer quadrant. Usually when the lump is going to develop, it usually develops in the upper outer quadrant, right? So from our exam perspective, no, whenever you're writing a competitive exam, they'll ask you what is the most common location. Remember, 60% of them is going to be associated. The 60% of the breast cancer is going to arise from the upper outer quadrant. 60% of the breast cancer arises from the upper outer quadrant. The reason being, the two important reasons. Number one, the maximum amount of breast tissue is present in the upper outer quadrant, and the most number of TDLUs, that is the terminal ductal lobular units, are present in the upper outer quadrant. So hence, most common is going to be your upper outer quadrant. The lower inner quadrant usually accounts for only 6% of the total breast cancer. So to put the things into perspective, remember, upper outer is the most common site. Lower inner is the least common site. So upper outer is the most common, lower inner is the least common site, right? Now, what are the findings that you're going to see? The first finding always starts from the center to the periphery. So what are the findings that you will see on the nipple that will tell you that it is breast cancer? Number one, you will find the nipple is going to be deviated towards the lump. It is going to be deviating towards the lump, and that is because, now why is the nipple deviating towards the lump? There are two reasons. Number one, as you know, all the Cooper's ligament are going to merge at the nipple area complex. So when the tumor infiltrates the Cooper's ligament are drawn towards the nipple, and those Cooper's ligament are going to the nipple. No? So obviously nipple will also be drawn towards the lump per se. So number one, it is because of involvement of Cooper's ligament. And second, it is associated with tumor fibrosis. It is associated with tumor fibrosis. Wherever there is fibrosis, the tissue is going to condense. And the condensation of tissue, let's say if the condensation of tissue is occurring in the upper outer quadrant, if it is condensing, obviously everything will move towards here, no? And that condensation will result in movement of the nipple towards the lump. As simple as that. Okay? Right. So why does the nipple deviate? The nipple deviates because of infiltration of the Cooper's ligament, or it can be because of simple tumor fibrosis. So that is the first finding that you will see for the nipple. Okay. The second finding that you will see, that is nipple not only gets deviated, it will also have circumferential nipple retraction. This will also have circumferential nipple retraction. Along with circumferential nipple retraction, this is also going to be associated with bloody nipple discharge. This will also be associated with bloody nipple discharge. But remember, whenever I talk about any nipple discharge, this is only possible if it's a ductal malignancy. It is going to be a ductal malignancy. And in breast, the most common type of breast cancer in terms of incidence is going to be invasive ductal cancer. Okay? So hence, invariably, you will see bloody nipple discharge is going to be present. So these are the various findings that you will see in the nipple per se. Right? Now, once you're done with the nipple, then you have the second findings, that is going to be skin over the lump. What are the findings that you will see in the skin over the lump? Now, the findings that you will see on the skin over the lump, number one, you can see presence of dimpling. Number two, it indicates presence of POD orange. And number three, there is going to be ulceration. So either there is dimpling, POD orange, or ulceration of the skin. There are three important findings in the breast cancer. Now, we all know when it comes down to dimpling, so dimpling is basically because of involvement of Cooper's ligament. It is because of involvement of Cooper's ligament. POD orange, it is because of infiltration. It is because of infiltration of subcutaneous lymphatics. It is because of infiltration of subcutaneous lymphatics. And this infiltration of subcutaneous lymphatics is going to result in edema of the skin. And this edema of the skin is what we call it as orange peel-like appearance, or peau orange, as simple as that. Ulceration occurs when there is a direct infiltration. When there is a direct infiltration, of tumor into the skin. There is a direct infiltration of tumor cells into the skin, and that will result in ulceration of the skin. Now remember, whenever there is presence of peau orange or ulceration of the skin, in breast cancer, we will talk about the staging as well. This will be called as a T4B stage, and ulceration is also a T4B stage. Dimpling, remember, does not alter the staging. That means if there is presence of dimpling, it does not change or alter the staging at all. Now, when you talk about the clinical findings in terms of palpation, so when you palpate the skin over the lump, so I'm just adding here. When the skin over the lump is palpated, see, all these findings that we've spoken, all these findings are inspectory findings. That means you're able to see. Now something you're going to feel now, right? So when the skin over the lump is palpated, there are two findings that you will be seeing. Number one, there will be something called as puckering. And number two, there is something called as tethering. So what is this puckering and what is this tethering? Let's try to understand. Now imagine if this is the skin surface that is present here, right? And imagine that there is, all these are the Cooper's ligament which is attaching to the skin surface, right? Just for the sake of perspective, I'm giving this is the skin surface that is present. Just to get a little bit of feel, let's say this is the subcutaneous fat that is present. And all these white strands that we have created, these are a Cooper's ligament which is attaching to the overlying skin. This is attaching to the overlying skin, right? Now imagine there is a lump in the breast, and that lump in the breast has become bigger, and it has infiltrated all these Cooper's ligament. Right, this lump is infiltrating all these Cooper's ligament. Now, as the lump is infiltrating all these Cooper's ligament, the Cooper's ligament are going to be drawn towards the lump. So, what is happening? The lump is now holding onto these Cooper's ligament. Right. Now, it's a very simple thing. The lump is holding the Cooper's ligament. The Cooper's ligament are holding the skin. Now, what I want you to do is I want you to put your finger on top of this, right? So I would want you to go and put the finger on top of the skin here, right? Now what I want you to do is, you are now putting the finger, there's a lump, you're able to feel the lump, right? You're able to feel the lump. Now what you have to do is nothing. You simply have to push your finger, right? So you're trying to roll your finger over the skin. You're trying to roll the finger over the skin where the lump is present. There's a lump, the skin is on top of it, you're trying to push the skin. Now, if it is a benign lesion, in a benign lesion, it will not infiltrate the Cooper's ligament, right? Just for the sake of understanding, to make it more dramatic, you see the Cooper's ligament is getting infiltrated. So this lump, which is a malignant lump, is infiltrating the Cooper's ligament. Just for the sake of understanding, just to make it more dramatic, I've made the tumor like this. So it looks like as if the tumor is infiltrating the Cooper's ligament. Now you're trying to move. What will happen? Will the skin over the lump move? Yes or no? Will the skin over the lump will move? No, because Cooper's ligament are fixed. You're trying to push. Now you're feeling that resistance. Now the resistance that you're able to feel on the skin over the lump. So when there is presence of resistance, when there is resistance of skin over the lump, the skin over the lump, this is what we call it as tethering, right? So that resistance, the skin is not able to move, now you're feeling that, that is called as tethering. You're feeling a tethered component. What is puckering? Now you're strong, right? Now you decide to exert more force. Now when you exert more force, what is going to happen to the skin over the lump? So this is the skin over the lump. This is the subcutaneous fat that you have. This is the subcutaneous fat that you have. This is the breast lump that is present. This is the malignant lump that you have. This happens to be your Cooper's ligament. This Cooper's ligament is infiltrated by this lump. To tell you it's a malignant lump, we said this infiltration will have this picture. So this is how you see it is getting infiltrated, right? I told you, take your finger and try to exert more force. Now what you have done is, you've taken your finger and now you're exerting more force. Now as you exert more force, what is going to happen? You're more strong, no? So as you exert more force, you will notice the skin is now going to get wrinkled. At this area where you're trying to exert more force, under the influence of the pressure exerted by you, you will see the skin is getting wrinkled. Now this wrinkling of the skin, you can see the skin is getting wrinkled. This wrinkling of the skin is what we call as puckered appearance. Normally for you and me, skin will move aram se. You can see the skin above the skin should move. But if you exert more force and you're trying to move it more, like this, you can see all these wrinkles are formed, like that you will see the wrinkling on over the, now see there's no lump here so you can't see the wrinkles properly, but as you try to exert more force you see skin is becoming like this. That is how you will see, and that is what we call as puckered appearance. So puckering is basically skin wrinklings. There's a skin wrinkling, and that is what we call it as the puckered appearance, right? So skin over the lump, when you try to do a palpatory finding, you'll have puckering and tethering. The tethering is the resistance, puckering is the skin wrinkling. Simple concept. Okay? So these are the findings on the skin over the lump, right? So we had the nipple findings, we had the skin over the lump we have associated. Now we are going to look at the axilla. So when you examine the axilla, usually it is going to go, tumor spreads into the axilla, so there will be presence of axillary lymphadenopathy. It will be axillary lymphadenopathy, and this axillary lymphadenopathy is usually a painless lymphadenopathy. It is usually a painless lymphadenopathy. This is going to be a painless lymphadenopathy, right? So there is findings on the nipple, findings on the skin over the lump, and then there is axillary findings that are present, right? Now when you talk about, because it's a breast cancer, you should know what are the routes of spread. The routes of spread for the breast cancer. When you talk about the routes of spread for the breast cancer, right? Number one is going to be via lymphatics. Number two, it is going to be blood, that is hematogenous. Number three, it can infiltrate directly, that is your direct route of spread. And the last one, it is going to be transcoelomic, via the peritoneal space, right? So it can go via lymphatics, hematogenous, direct, as well as transcoelomic. Usually when it is going to via lymphatics, the most common lymphatic channel or the lymph nodes is going to be involved. It is going to be your axillary group of lymph nodes. It is going to be your axillary group of lymph nodes. If it is hematogenous, the most common site where you will see it is going to be in the long bones. If it is bones is less than long bones, let's say it's bones which are more commonly affected. Bones which is going to be more commonly affected. If this is not there, then it would like to go to lungs, right? For direct, when it spreads, most commonly it is going to go down to the lungs, right? And transcoelomic, it will go into various abdominal viscera. Now, what is interesting for us to know is when it spreads to the bones, how does it reaches to bones? Now, it reaches to the bones via the help of Bateson's plexus. Now, what are these Bateson's fluxes? These are your valveless venous communication between the vertebral column as well as your breast. So when the tumor infiltrates to Bateson's fluxes, it usually reaches onto the vertebra, and that is why when it reaches to Bateson's fluxes, the most common bone that is involved, it is going to be the lumbar vertebra. It's going to be lumbar vertebra. If it is not in the context, the next best answer is going to be femur. Along with femur, then it is going to be your thoracic vertebra. So you have the lumbar vertebra followed by femur followed by thoracic vertebra. These are the sites where the metastatic lesions are going to present. Now, along with that, when you talk about what are the types of secondaries, right? In bones, you have two types of secondaries. One is your osteoblastic secondaries, another one is osteolytic secondaries. Now, here in breast cancers, you can see both. Remember, it is osteolytic secondaries, which are more common when compared to osteoblastic secondaries. Now, because osteolytic secondaries are more common, breast cancer is usually associated with pathological fractures. Breast cancer, it is associated with pathological fractures. So when I say what is a pathological fracture? So when we talk about a pathological fracture, it is a fracture without any trauma or a trivial trauma. That means an insignificant injury resulting in a long bone fracture indicates a pathological fracture, right? So all these are important contexts that you need to remember, that you know how the breast cancer is going to spread across, right? How it is going to spread across, right? Now, whenever you have a patient with breast cancer, how would you like to evaluate, right? Investigation for breast cancer. There are no points for guessing at all. We have already discussed this. So when we talk about the investigation for breast cancer. Now, as we said, any patient who presents to us with the lump in the breast, the standard protocol that is going to be assessed is going to be your triple assessment protocol. So you will have to follow the triple assessment. There is no point that you escape the triple assessment and try to get a diagnosis in breast lump, which is not acceptable. In the triple assessment, the first step was clinical examination. It is going to be a clinical examination. Second is going to be a radiological assessment. It is going to be your radiological assessment. And the third one is going to be your true cut biopsy. You have to go ahead with true cut biopsy, right? So there are 3-step procedure that you have to follow in order to get to a diagnosis, right? Now, when you talk about radiological assessments, obviously we have already discussed what are the findings on the mammograph, on an ultrasound, and true cut biopsy. Obviously, you will have the differentiation, which I've already dealt with. Now, those who are preparing for the competitive exams, the question that I usually ask is, what is the investigation of choice for diagnosing breast cancer? That means, how do you know that the lesion that you have is a breast cancer? The only thing that it can tell you is going to be your true cut biopsy. It is going to be a true cut biopsy. The second question will be investigation of choice for staging breast cancer. Now, when you talk about breast cancer staging, I need to know whether it is limited to breast or spread to the body, and that is done with the help of PET-CT. That is a positron emission tomography with computerized tomography, a PET-CT. Now, if your examiner in Viva wants to, play with you, he'll say in a PET-CT, what is the isotope used? Remember, the isotope used is going to be 18FDG, right? That is going to be your fluorodeoxyglucose. Okay. So 18FDG is the isotope that we are going to use it for PET-CT. So the investigation of choice for diagnosis is going to be true cut biopsy, but for staging it is going to be PET-CT, right? So before we talk about any further component of management, we'll talk about how do you stage the breast cancer. Let's talk about the breast cancer staging. So we have a classification which is called as the TNM classification for breast cancer. This is what we call it as the TNM classification for the breast cancer. So in the TNM, we classify the entire breast cancer into three components. T basically assesses the size of the lesion. N usually assesses the status of the lymph node. And M tells you the status of metastasis. M tells you the status of metastasis, right? So in a TNM classification, T is the size of lesion, N is the status of lymph node, M is the metastasis. Now, how do you assess? Now, there are different ways you can learn it, you can remember, mug it up, all that nonsense you can do, but that's not my style. Okay? So I want my students to understand it, to picture as a surgeon pictures it. You need to, have a sound understanding of what you're dealing with. For that, we're always ready. Now, when you talk about the breast cancer, let's say, let's say this is the representation of the breast that you have. Let's say this happens to be the pectoralis fascia. Behind the pectoralis fascia, you have the pectoralis major muscle. So let's say this is the pectoralis major muscle, and then you have this serratus anterior group of muscle. This is your serratus anterior group of muscle, right? So this is your pectoralis major muscle. So the pectoralis fascia, then you have the pectoralis major muscle that we are depicting right now. Now below the pectoralis major muscle, you have the serratus anterior group of muscle. So this is the serratus anterior group of muscle. This happens to be the nipple, right? Behind this, you have the pectoralis minor. So this is where you have the pectoralis minor muscle. So this is the pectoralis minor muscle. And behind this, you have the ribs and the chest wall, right? Now this, for the sake of TDLU, I say this is going to be your terminal duct. This is going to be the ampulla. This is the major duct. These are the branched or the minor ducts, and this happens to be the lobules. This happens to be the lobules, right? So just for the sake of understanding, I'm just drawing the depiction of your TDLU, sir. That is your terminal ductal lobular unit, and they all open into nipple area complex. As simple as that. Now you have seen this is the skin that is there, right? Now for the sake of understanding, let's say this is the representation of the skin that you have. And this is the nipple area complex. Okay. Now, when you talk about the TNM classification, we need to analyze the size that you have, right? So if a lesion is here, it is called a small one. I'm talking about it will arise from the ducts only. I'm just giving you in this context. Okay. So if the lesion is this, it is T1. If the lesion is this, it is T2. And if the lesion is this, it is called as T3, right? Now, meanwhile, you will also see that these strands which are going to be flowing across here. Now, all these strands are what we call it as the Cooper's ligament. So, not worried about the Cooper's ligament. Let the Cooper's ligament stay where they want to, right? Right. Now, then you have, so you have the T1 disease, you have the T2 disease, you have the T3 disease. Now, what is a T4A disease? A T4A disease is going to be a lesion that is going to be somewhere like this. This is a T4A. If it is involving skin, it will become T4B. If it is involving both, it is called as T4C. On the other hand, if it is going to involve, a good chunk, more than 1/3, let's say, this is your T4D. Okay, so this is how you remember TNM staging. Now if I want to add a little bit of color to it, so I can do like this, right? So this is a T4D. Now what do you mean by this? Now if there is a tumor, if it is less than 2 centimeters, here it is size less than 2 centimeters. It is size between 2 to 5 centimeters. Size more than 5 centimeters. So if it is less than 2 centimeters T1, 2 to 5 centimeters T2, more than 5 centimeters is a T3 disease. As simple as that, right? Then you have any size that is involving the chest wall, this is T4A. Any size involving the skin, it is T4B. If it involves both chest wall and skin, is T4C. And if it is like an inflammatory breast disorder, it is going to be T4D, right? So this is your T staging, as simple as that. Now, if just for the summarizing way, I can say T4A, it depends, it says that any size involving chest wall. Now from our first lecture of anatomy, I told you chest wall is made up of ribs, intercostal muscles and the serratus anterior group of muscle. Here you can see it is involving the serratus, it will become T4A. T4B is any size of the tumor, any size involving the skin, it is going to be T4B. T4C is basically a combination of T4A plus T4B, that is both skin as well as the chest wall. T4D, it is the inflammatory breast cancer. It is a inflammatory breast cancer, and this inflammatory breast cancer, which is going to involve more than 1/3 of the breast skin. If it involves more than 1/3, that inflammation is there present in more than 1/3 of breast skin. More than 1/3 of breast skin is associated with inflammation, or you can see there is erythema over the skin surface and then it turns out to be malignant. This is what we call it as inflammatory breast cancer. Remember, it is associated with the worst prognosis. Okay? Now you go find anywhere you want in the internet, if you can, or anywhere, any platform across, if you can find a better explanation of a T staging else than this, then we'll talk about it, right? T1, any size less than 2 centimeters, size less than 2 centimeters, T1, 2 to 5 centimeters, T2 disease, more than 5 centimeters is T3. As you can see, all of them are limited to breast only. If it is involving the chest wall, now involvement of pectoralis muscle does not mean chest wall. Chest wall is serratus anterior, it is going to be ribs and the intercostal muscle, right? Then you have T4B skin, T4C is going to be both A plus B, T4D is your inflammatory breast cancer. Now this is what you have to keep in mind. Now when you talk about the lymph node status, again, rather than trying to memorize it, we will go in our style, right? So what is our style? Same. You have, this is the neck that is present. This happens to be the axilla. So let's say this is the representation of the axilla that we have, right? Now this happens to be the axillary groove. You keep this as the axillary groove. This is the suprasternal notch. This happens to be the sternum. This is the xiphisternum. This happens to be the clavicle that is present, right? So when you talk about the lymph nodes, no? When you talk about the lymph nodes, you have the anterior axillary group of lymph nodes, you have the posterior axillary group of lymph nodes, you have the lateral axillary group of lymph nodes. Then you have the central, this is going to be apical, that is going to be infraclavicular, there is supraclavicular, then there is internal mammary group of lymph nodes, and then there is set of these lymph nodes which are called as the Rotter's group of lymph nodes. As simple as that. Okay? Now, we all know all these structures. Just for the sake of understanding, I'm going to quickly talk about it. These are your axillary group of lymph nodes. This is the central group of lymph nodes. This is apical. Now, apical is also called as infraclavicular. This is what we call it as infraclavicular. This is your supraclavicular. This is your supraclavicular. This is your internal mammary group of lymph nodes. This is your internal mammary group of lymph nodes. These happens to be your Rotter's group of lymph node. This happens to be a Rotter group of lymph node. And we all know that this is going to be the breast. So this is where the normal orientation of the breast is going to be present. So this is how the breast is present. So this is the status of the breast. Now, if the tumor is present in the axillary group of lymph nodes, if the tumor is present in the axillary group of lymph nodes, it is going to be N1. N1 is axillary group of lymph nodes are involved, but this time they are mobile. That means it's a single node. Now, if the tumor becomes large and it starts infiltrating all the nodes and they all get fixed, now this is what we call it as N2A, where the axillary group of lymph nodes are involved, but this time they're getting fixed. Why are they become fixed? Because the tumor starts to infiltrate and it involves multiple nodes and they coalesce together, and that collasion is what we call it as fixity. That is going to be N2A, right? Now you have your N2B. Now N2B is involvement of internal mammary group of lymph nodes. If a tumor is involving internal mammary group of lymph nodes, it is N2B. N2B is involvement of internal mammary group of lymph nodes. IMLN stands for internal mammary group of lymph nodes. Now what is, sorry, this is N2A, N2B, sorry, right? It's going to be N2B. Now you have, if there is involvement of the apical group of lymph nodes. If the apical that is involved, it is your N3A. Now, if there is involvement of both internal mammary as well as the axillary group of lymph node, that is, if there is involvement of, so I'm just going to add up here only. So N3A is apical, N2B is internal mammary, N1 is going to be axillary, N2A is going to be axillary, which is going to be fixed. Yahan tak clear? Now, what is N3B? N3B indicates involvement of both axillary group of lymph nodes as well as internal mammary group of lymph nodes. If you have anytime doubt, no, ki how do you remember it? N3B stands for both. Both means what? Axillary group of lymph nodes as well as internal mammary group of lymph nodes. N3C is going to be involvement of supraclavicular group of lymph nodes. N3C is involvement of supraclavicular group of lymph nodes. Again, a clear picture. Involvement of axillary nodes mobile, it is going to be N1 disease. Involvement of axillary nodes, they are fixed. It is your N2A disease. What is N2B? B is going to be on the internal mammary. N3A is going to be supraclavicular. N3B is combination of both. N3C is going to be supraclavicular. As simple as that. Okay? So this tells you about both T as well as NM status. Okay? Now, if you are wondering, we did not label here. I'll label it quickly here. This is the skin that we're talking about. This happens to be the pectoralis fascia. This happens to be pectoralis fascia. This is your pectoralis minor muscle. This happens to be the pectoralis major muscle. Right? So this happens to be your Cooper's ligament. This happens to be your Cooper's ligament, right? Now M is quite easy for us to remember. M exists only in two forms. There is M0. There is no evidence. There is no evidence of metastasis. Metastasis is distant spread. M1, there is evidence of distant metastasis. So M0, there is no evidence. M1, there is evidence of distance metastasis. Clear? So this is how you will understand your TNM classification. Okay? So again, do not try to mug up the TNM classification. Just go through this particular representation. Now you know the T categorization. How do you do a T classification? How do you do an N classification? How do you do an M classification? Combination of these will give you staging that we'll discuss tomorrow. So tomorrow, come back at 9 o'clock. We'll talk about staging and the management of breast cancer. Okay? So until then, thank you so much for joining today. We'll resume back tomorrow evening at 9 o'clock. We'll have the same BLS series. You know where to find your notes. It is shared on the Telegram as well as Instagram. It is called as the Surgery Guy. You can find this on both Telegram as well as your Instagram group. It will be by my name, that is Dr. Sandeep Seeram Reddy. So if any questions, any queries, do feel free to reach out, right? Thank you so much for joining today. Tomorrow, come back, I'll teach you how to do staging, and that too without cramming your brain. It will be logical, it will be clinical, it will be the approach as a surgeon that you should take. Tune back tomorrow and will not disappoint it. Thank you so much for joining. Good night. See you tomorrow. Bye bye.